Welcome everyone to our 12th seminar of the Aphasia CRE seminar series. I'm Caroline Baker, co-facilitator of the seminar today. We acknowledge that this event and our participants are located on the lands of many traditional custodians. We pay our respects to Indigenous elders, past, present and emerging, and extend this respect to any Indigenous participants joining us online today. Before I formally introduce our speaker, Professor Dominique Cadilhac, Chief Investigator of the Aphasia CRE, let's cover housekeeping and ways to engage with us today. You've automatically had your video turned off and sound muted upon entry to the seminar. Please ensure this remains in place for the duration of the seminar to enhance everyone's Zoom experience. Our apologies in advance if there are any disruptions to your viewing during the seminar. Occasionally attendees join in late. You can minimise your Zoom gallery to view the slides as best as possible. Thank you. This seminar is being recorded on Zoom. Thanks, Dom. And will be available to access along with past webinar videos via the website. Just click on the resources tab, and videos are usually uploaded 1 to 2 weeks after each seminar. Also a reminder that the CRE has developed a repository of aphasia-friendly COVID-19 resources. These have been sourced from across the world, and you are welcome to use these resources in your practice. Questions for this seminar will be aided by the use of Slido. You can log in anonymously or with your name and ask a question. Our event code today is Aphasia CRE. Thanks, Dom, for the next slide. Enter your question under the questions tab at any time throughout the presentation. You will also be able to see questions asked by other audience members. Like a question by clicking on the thumbs up to show those of most interest to the group. It's a great way to engage with the presentation experience. And Professor Cadilhac will answer as many questions as time will allow at the end of the presentation. And please engage with us on social media via Twitter or Facebook. Feel free to tweet along today and use the hashtag AphasiaCRE so we can follow along. We welcome you to join us as a member of the Aphasia CRE. We invite people with aphasia, their family, friends, health professionals, researchers and organisations to our Aphasia CRE community of practice. Benefits to members include a monthly newsletter, updates about events and activities, contributions to research, networking opportunities and more. The CRE is always looking for financial support. If you wish to donate, please see our website homepage for details. Now I am absolutely delighted to introduce to you Professor Dominique Cadilhac. Professor Cadilhac is an expert in health services research within the field of stroke with application of her work in acute, rehabilitation and long-term care. She has published over 220 articles and has a clinical background in nursing. She currently heads the Translational Public Health and Evaluation Research Division in Stroke and Ageing Research within the School of Clinical Sciences at Monash University. And she is the head of Public Health Stroke Division with the Florey Institute of Neuroscience and Mental Health. She is the Data Custodian for the Australian Stroke Clinical Registry and co-led the Victorian Stroke Telemedicine program. Her skill set includes epidemiology, implementation science, telehealth and economic evaluation. Her presentation is entitled The Australian Stroke Clinical Registry, Progress over 10 Years and Relevance to Those with Aphasia. Can we do more? So thank you, Dominique, over to you.
Thank you, Caroline, and thanks everyone for joining us today for my presentation, which I hope will stimulate some thinking and sort of bring people up to speed as well as to what we've achieved over the last 10 years with the National Stroke Registry program that we've been conducting since 2008. So I'm going to commence the webinar today with an overview of registries and why they're important, give you a whistle-stop tour of how we've got to where we are today, and talk about some of the data collection and the infrastructure, how the data are being used for quality improvement, given that's the primary purpose of the registry, as well as how we're maximising the utility of the data. I'll spend a little bit of time talking about the capture of patient-reported outcomes, because I think that's quite important when we're thinking about people who have aphasia as a consequence of having a stroke, and how we might be then looking to capture information on people with aphasia as we develop our work programs through the CRE in collaboration. And the first thing I really want to say is that all of this is a collaborative effort. I may be one of the figureheads for the registry, but none of it is possible without a very broad and clever team that is interdisciplinary, that represent clinicians, researchers in this space, as well as people that have expertise in data management, health information management and information technology. So as a collective, it takes a village to build a registry, and we have some wonderful people that have been with us along that journey. And the founding consortium partners are the Florey, the George Institute for Global Health, the Stroke Society of Australasia and the Stroke Foundation. And we also have our statistical hub based with my team under Monique Kilkenny at Monash University. So why clinical quality disease registries? Look, you can't have a registry for absolutely everything. And so, you know, it's just impossible and infeasible really to fund them, even though, you know, we always get very focused on our specific area. So it has value from a national perspective if the condition has serious consequences associated with poor care, and there is an evidence-based sequence of care that has been proven to improve outcomes. Variation in outcomes can be identified and addressed, and the economic, what they have found through some research undertaken by the Australian Commission of Safety and Quality in Healthcare is that if you invest in clinical quality disease registries to monitor care across healthcare providers, then there are benefits to that. So there's a cost-benefit ratio of the investment of ranging from 2 to 1 to 7 to 1. So they are, you know, very important if they're put in place for the right conditions. They need to have benefits over long periods, and improvements can be shown to be found at a clinical level via feeding back the data to the clinical space. And the data also have a secondary purpose for research and as well as quality assurance. So how does this all work? So the Australian Commission on Safety and Quality in Healthcare provides some really good resources if you're interested in this. The main thing to understand is that at the heart of it is our data. The fact that we require information and we can generate knowledge that allows us to take information that shows us how we adhere to evidence-based practice guidelines, and then there can be some regular feedback and monitoring, but that also that there is something done to improve clinical care. So there's no point continuing to just collect data but not act on it. And this is where we get this improvement cycle. And I think the other thing that's really become apparent through the importance of having registries that become part of this whole quality cycle that occurs within health services and health systems is that we have these new clinical governance standards, and within them now, a hospital or a healthcare provider can use this for accreditation to show that they are providing evidence-based care, which is standard 1.27, as well as the fact that they are routinely monitoring and doing something to address variation in clinical practice in health and health outcomes, which is standard 1.28. So these are things that we've had to really use as a scaffold for justifying why it's important for stroke to have a national clinical quality registry, as well as the fact that we have very well articulated clinical guidelines, and I'm sure some of you have contributed to those, but also that we have evidence of variation in practice that was emerging out of the national audit which preceded this clinical quality registry, where we routinely monitor data on all patients that come into hospital with acute stroke. So the Australian Stroke Clinical Registry was established to monitor clinical care and health outcomes for acute stroke and admissions for TIA, because TIA is a precursor to a full stroke event, and it is important that they receive the same evidence-based care, in particular around secondary prevention. Because it is important that we capture data on all patients, we use an opt-out approach, because if you had to do an opt-in approach where people sign a consent form, you will get more selection bias. And we also have a waiver for people who die in hospital, so we're not contacting their families unnecessarily about holding data about their relative in our data system. Data collection is online, so it allows for real-time entry of data as necessary. It's also, since 2016, been integrated with other stroke data management systems, and this is referred to as the Australian Stroke Data Tool. So the National Audit Program and the Australian Stroke Clinical Registry Program run off the same system, and that just allows us to prevent duplication of effort. Hospital staff can access online real-time data reports and export their data, so they can start to interrogate it to improve clinical care. And uniquely with our program, we follow up all patients now at 90 to 180 days between that time period. So we also get their perspective of how they've recovered, as well as understand survival, readmissions and things like that. We've previously published on the protocol for establishing the Australian Stroke Registry, so you're welcome to have a look at that if you want more detail of how it all came about. So where are we at today? We've got really good coverage across the eastern seaboard of Australia, and we also now have some more sites joining us in Western Australia. We are hoping to have 9 sites join us. So we've reached an important milestone. We were celebrating having over 100,000 episodes of care in the registry. You can see now, as of yesterday, we are, or a couple of days ago, we're up to over 107,000 participants that have had their data recorded. We have 86 hospitals approved, I think, and we also have what's called the opt-out rate, which is quite low, and this is what you expect. So this is a sign of acceptability of the registry to our patient cohort. This indicates to us the number of people who don't want us to hold their data. So we would expect for a properly conducted registry that this would sit under 5% to be acceptable. So we're very pleased with that. At the moment, we have 63 sites actively contributing data. And this has sort of dropped off since last year because of some funding shortfalls in New South Wales, whereby some of those sites are no longer being supported by government to contribute data, which is a shame. Now, as I mentioned, the Australian Stroke Data Tool is I guess, the infrastructure, the integrated data management platform that we use. And what it means is that within a hospital, if you're collecting information on patient Smith, and you need to collect data for more than one program. So you're collecting data for the Australian Stroke Clinical Registry, but you also want to do your national audit, which is a deep dive on a lot of clinical variables, but on a small number of people. It means that that data can automatically map across where it overlaps, and only the fields that need to be collected for that person that are missing then get entered. Data can also be extracted and submitted into other systems, and we're working hard to integrate that more with programs like the International Thrombolysis Registry and the Imaging Registry that's being overseen by Mark Parsons and others through NHMRC grants. So how does this work? You have to have very clear governance with a registry that holds personal information, that has a lot of data from a lot of different hospitals, and there are multiple people involved in all of that. So we have a steering committee that's chaired by Professor Sandy Middleton. We also have a management committee to which I report to and my team at the Florey. So the little orange triangles in that diagram just depict, I guess, the engine room components of the governance in terms of the way we do the analysis and, you know, the system we have in place for, you know, contacting patients, liaising with hospitals, helping them with their ethics, checking and maintaining data quality, keeping policies up to date is a huge amount of work by the team at the Florey with support from Monash. We also have an independent research task group, because one of the purposes of the registry is to have the data used for a secondary purpose like research, whereby de-identified data might be interrogated, or we do ask patients who complete our survey at 90 days whether they wanted to be contacted for further research. So if you're interested in chronic stroke, there is a ready cohort of patients that we might be able to contact on your behalf, and they might be able to contribute to a project. And we've had several research groups across Australia access patients that way through the registry. And because of the focus on reperfusion, endovascular clot retrieval, there's a lot happening in telemedicine. We have a separate working group that also has oversight of that. And we also need to liaise directly with the Australian Stroke Data Tool Coordinating Committee, which has different data custodians from all the different facets that make up a much broader data dictionary that we've created as a group to allow for a whole range of different programs or research to happen off that infrastructure, not just the registry program or the audit program. And then that feeds up to the Australian Stroke Coalition. So I regularly have to report to the Australian Stroke Coalition and our other consortium partners, which are in fact the Stroke Society and the Stroke Foundation. So it is an end-to-end clinician-driven, you know, field-driven registry program that has very broad governance and has mechanisms for feeding up international policy. And we have a new committee that I'm pleased to announce has met twice already this year for improving care quality based on the data, and that's chaired by Jeff Cloud. So I guess one of the biggest things that's happened since we moved to that integrated platform is that where we all used to just collect the green, you know, very tight process of care measures, which were basically whether or not someone got thrombolysis, they got onto a stroke unit, whether or not they got a discharge care plan or had antihypertensive medications prescribed at discharge, there became the need to grow the registry and grow the options for the data collection. So you can see here there are now multiple programs that are available that hospitals contribute to based on what they want to collect data on. So if they're interested in swallowing variables, they'll include they'll be part of the RED program, and if they're interested in early mobilisation, they would also contribute to the RED program. If they are a site that conducts endovascular clot retrieval, they would be part of the black or violet data collection programs. So some of the minimum data that we have on processes of care. Now, by processes of care, that's our way of saying what are variables that align to clinical interventions that reflect recommendations in our clinical practice guidelines. So that's what I mean by that. So these are the sorts of clinical processes that we collect. So arrival by ambulance, secondary prevention medication at discharge, being provided with a care plan. And look, there isn't a lot of evidence around that. However, when we had our national forum on what measures we should include, the consumer voice really rang through in wanting that to be part of our minimum data. So that's always been maintained. We've also got these extra measures on endovascular clot retrieval and some other measures on telemedicine, because that helps us deliver best practice care if we can treat more people with thrombolysis, but also keep an eye on timelines and the number of people being treated within 60 minutes. We've also created an emergency department minimum data set that was released in 2019, and we also have available fever, sugar, swallow optional module, which, because they are now part of the clinical guidelines and they really do refer to nursing and allied health practice, and it's important that we made those items available. The emergency department minimum data set captures information on patients that may be transferred out of a hospital in a regional area, and that we weren't capturing the fact that they were giving them thrombolysis in their hospital and then forwarding on that care onto another provider. So this now allows for those hospitals in that situation where they might transfer some of their patients out to capture their activity around stroke. So one of the important things that we need to do with a registry is have very tight standardisation of the measures, but also ways in which we check the data centrally. So we have a whole system in place that matches what is best operating principles and standards for a registry, and we are seen as one of the leaders in this space, which I'm very proud about. So a lot of the information is available online, so you're welcome to have a look at that. But we do run random medical record audits to check the data. We send back to hospitals some data quality reports if we think there's some anomalies with the data, and we just try and make sure as best as possible that that data reflects care in the hospital, and it's not because there's a lot of missing data or they've only given us cases from their stroke units. And we do that by also looking at case ascertainment. So we request a list of all the discharge codes for stroke from that hospital in the annual year reporting period, and then we match that up and have a look at how many cases we received from that site, so we can also report on case ascertainment, because that then goes back to selection bias. So how do people enter the data? One of the, I guess, the barriers to participation in the registry is the fact that it does require some manual data entry. We wouldn't have a registry if all this information was sitting in administrative data sets already that a hospital captures within their own local electronic medical records. So we've got about, just over a third of sites having to do full manual data entry. We've got 42% of our sites that are able to import part of their data and then do the remainder via manual data collection. And then we've got 1 in 5 of our hospitals using a third-party app to directly upload from their local system into our system, which is fantastic. And we're hoping to use technology more to help support sites to do that. And the median time to completion, but it does depend on what is being done, is about 20 minutes. Now, follow-up, is one of the unique facets of the registry, and we contact people from 90 days after their stroke onset up until about 6 months. And if we haven't caught them by then, well, we just have to, we leave it. But we do an annual linkage with the death registry every year, so we at least have survival status on everyone, and we accumulate that. And that's so important, because if people have volunteered to be contacted for further research, but they let us know that in 2009, I want to know in 2019 if they're still alive, if we're going to try and attempt to contact them. So we do capture a range of information. Importantly, we collect the modified Rankin scale, and quality of life is through the Euroqual 5D. And if people are aged under the age of 18, because this is not just a registry for adults, they have an age-appropriate quality of life tool called the PEDS-QOL. Now, our process is that we send out a postal questionnaire at least twice, and if we haven't received a response, we will phone people, and that's just our process for doing that. And through that kind of system, we usually get about 70% response rate, which is more than adequate for such a large program of work. We have had some major achievements with OSCAR. Now, in the beginning, this just all got funded through, patchy grants and research grants, and the real leverage came from a partnership grant that I got with the Stroke Foundation, Queensland Health, and various state governments, which allowed us to do a very large program of work to upscale across Queensland, but also do some, feasibility data linkage programs. And through that, because there is an obligation that we publish our work and that we make our work visible, we have got over 30 publications now, and others outside of our collaboration have also been able to leverage and use the data for various publications too. So the ones I'm referring to are the ones that sort of have emanated out of the initial grants that help get this all off the ground. But since 2012, we've been able to transition and come off research funding, and it's now fully funded as the core activity through government funds. And the way in which we feed back data to hospitals, because this is the important element that I raised at the beginning, is through data reports that we provide. We have an annual report every year, and they are listed on our website if you want to have a look at some of those. The annual report includes benchmarking. We also provide reports to state governments and to CEOs, and these are tailored based on each clinical network within each state. The system itself has on-demand summarised data, which provides national, state and peer benchmarking. And we also, clinicians that are part of the program can put their data at any time. We've also run or worked with others to deliver some quality improvement programs, and I'll describe those briefly. And we also provide a whole range of webinars, frequently asked questions, and we do the routine audits. And we now have this clinical quality improvement committee that's really going to help look at the data that we're generating and look at how we can support hospitals to use the data better to address barriers within their local system to improve stroke care. So this is just an example of an individual report. So Hospital 30 would receive a report on their stroke care after we've done our annual report, and they would know how they compare to a peer hospital, as well as national and state benchmarks. And we provide very detailed and rich information. They can also compare information by stroke type and other things. But this usually comes out, 18 months after the data set's locked, because it does take us a bit of time to prepare all this information. But, on the whole, the benchmarks stay fairly stable. We also provide these process control charts. So this little red dot here, I hope you can see that well, is a hospital. That hospital's provided about 400 cases in that period that we're looking at. And it just shows you the distribution of patients and the adherence to number of people getting onto the stroke unit. So on average, we get about 78% of patients on the stroke units, but there's a whole bunch of hospitals getting much greater proportions, and then there's a whole bunch of hospitals that aren't getting good access. So how these data help us is to think, okay, well, what are these hospitals doing that these other hospitals could learn from? And part of that quality committee will be to sort of help unpack that and help support sites to ensure that they have, ways in which they can communicate about their stroke unit access and capacity and things like that. Now, we've also spent time surveying our hospitals to ensure that we are providing, and collecting data on things that are useful. And these are the list of variables that clinicians find most useful to them. So you can see there that swallow, screen and assessment gets a look in. And these are the quality improvement projects that hospital use of their data. So again, there's a big focus on swallow assessment, which is relevant to speech pathology, as well as, the door in, door out or door to needle times, because for every minute that you delay treatment, that affects at least 1 day of healthy life. That's what's been estimated. The other area is discharge care planning, and I think that's because as an interdisciplinary group, with patients staying in hospitals for shorter periods of time, that discharge care planning to support the patient in their transition to home is so important. We've also asked them, the contributors of the data, do they believe that there's been service improvements following OSCR involvement? And we're very pleased that the majority of them do. And then this comes to how we have undertaken various projects to support hospitals to use their data. And this is, the model is, well recognised. It's the Plan, Do, Study, Act model. Most of you working in healthcare, or if you've dabbled in quality improvement or quality assurance, will come across this model. But at the heart of it needs to be standardised data, because you want to measure at different time points exactly the same thing. If you don't do that in a standardised way, how do you know that it's something that you did to improve care or just an anomaly with the data? So this is an evidence-based approach to audit and feedback, and that's how the OSCR data can get used in various programs. So with the Stroke 123 program, which was at the heart of the NH and MRC partnership grant, we conducted a before and after study in Queensland, and we used the rest of Australia as a natural experiment, because this was the only state at that time running that type of integrated and systematic quality improvement program that was also utilising the registry, and for the first time we were feeding back the 90-day patient outcomes. So what did it entail? It entailed us having a workshop with a clinical facilitator, so that was someone from the Stroke Foundation that made a time to go into the hospitals. It had a component of providing feedback about the data and against different benchmarks. There was an education component, and there was an action planning phase whereby barriers to care in that hospital were discussed, as well as the enablers, and then strategies to overcome the barriers were put in place and agreed upon, and then the facilitator followed up with them. And then through OSCR, they had access to real-time tracking and monitoring of the priority areas that they wanted to work on. So these were, at the time, this was a range of variables that they could choose to work on and were fed back data on. So the way we assess this is that we had a composite measure of these indicators, and the pre-composite overall for the number of hospitals that participated was 57%, and what we achieved at the end of the program was 75%. So that means that on the whole, there was this big shift in overall clinical practice through the program of work that had been put in place during the Stroke 123 project. Now, in part, there had been a financial incentive payment put in place, and this was part of the work that Rowan Grimley led through his role at Queensland Health. And that meant that hospitals got a payment if they enhanced or set up their stroke units and got at least 75% of their patients onto the stroke units. That was a really strong driver. And then our program had this value add on top of that. So we were very pleased that it was working, and it was working very well. And in fact, when we compared to the rest of Australia, it really demonstrated to us that that type of model works. Since then, we have obtained feedback and we've done further work in Victoria, which we're writing up at the moment. And this covers off, the fact that clinicians have a very limited number of hours that they can contribute to these things. So in StrokeLink, it was one half day that had to be contributed, whereas with our program that we trialled in Victoria following feedback that we'd gotten some piloting, we split it up into 2 different workshops. So the first workshop was virtual like this. We'd go through the data with the team, and then they would really understand it and start to talk and discuss what they might want to work on and what some barriers and enablers are. And then there was a face-to-face workshop, and then also a support period. So we're writing that up now, and I'll be pleased to share that with you all soon as part of that process. I think the other great achievement we've made over the last 10 years off the bat of commencing Stroke 1, 2, 3 is data linkage across the whole patient journey. And we now link our data successfully with Ambulance Victoria, with the National Death Index, with hospital emergency and admitted episodes data, as well as PBS and MBS. So you can just imagine this national platform of data that could be used to interrogate a whole range of questions and not just be limited to a very thin slice of that patient journey, which is often focused just on the hospital care, but so much more happens to people out of hospital, either before their stroke or after their stroke. And with data linkage, you can look back 5, 10 years if you want and understand what was going on before that person had their stroke. You can look forward and see things like whether people have been adherent to their medication, whether they've been put on chronic disease management plans, whether they've been seeing dietitians or being referred for team care arrangements in primary care. So there's a whole bunch of work that's coming out of this initial system, and it's now part of we've got this national Data Linkage Registry interest group that Monique Kilkenny is heading up on behalf of our collaboration with this. And if you want more information, there's a website that you can go to. So what did we do? Basically, the first big project that we did was to link data with hospital care and emergency department data sets, as well as the National Death Index. So we linked up over 15,000 records of stroke and TIA from 40 hospitals between 2009 and 2013 from 4 different jurisdictions, so Western Australia, Victoria, New South Wales and Queensland. And from that, we've been able to, interrogate the data and determine that A, it's feasible, and B, we don't have to ask clinicians to give us more information about their patients. If I want to know if someone's got diabetes or atrial fibrillation, they don't have to put that in OSCAR. We can get that from the ICD-10 codes. So here's some of the work that we've been doing in preparation for this particular seminar, and we can maybe have some questions about this. But the code that refers to someone having dysphagia or aphasia is R47. Now, in different countries, there's more fine-grained breakdown, so that would include dysarthria as well. We can't unpack that with our code, but and it might reflect the fact that we found that 44% of the cohort had either a dysphasia or an aphasia in this linked data set. So that's just something to think about. These are preliminary data, they're not deciding, it's literally hot off the press. There was an opportunity for us to explore this. What's of interest is that older people tend to have aphasia more. Very similar, there's no difference by gender, and probably not surprisingly to those of you that work in this space, that most of it's driven by people that have an ischemic event. Now, there's been a recent publication that came out only the other day, 2020, in the Journal of the European Academy of Neurology, and it was interesting that they reported that 44% of cases, this was a sample size of 151 first ischemic strokes, had dysarthria. and 23% were classified as having aphasia. So I'm thinking that this is an overcall, but I think what it also tells us is how do we inform better clinical coding for this condition and make sure that in Australia we get better coding and more fine-grained coding if this is important to split out. So what did we find with these patients? So their self-reported outcomes. You can see here the blue bar is those with dysphagia or aphasia based on that code. And you can see here on the whole, apart from mobility, apart from now, I looked at this yesterday. Apart from mobility, yes, apart from mobility, all the other domains of the EQ5D have a greater, are impacted on more by people that have dysphagia and aphasia. So that may not be surprising to you. We know there are reports of poorer quality of care. There is also a 5-point median difference in overall health, best possible health. Now that's not a clinically meaningful difference, but it's still an important difference to consider. What we've found also is that readmissions to hospital seem to be fairly consistent with within the first 6 months of stroke, maybe a little bit greater within a year, but deaths within a year overall are higher in people that have dysphagia and aphasia. But these data have not been age or sex adjusted, so I just want you to bear that in mind, and it's just for a discussion point in showing you the type of data that we could explore with these linked data sets. The other thing that we've done is we've got hospital clinical costing data for stroke, and we haven't age or sex adjusted these either. But overall, our median costs are around $8,000 for these patients. And we had a high proportion of these cases that we classified because they had an R47 in their codes of having dysphagia or aphasia. But you can see consistently on each of these costing buckets that if you've got aphasia or dysphasia, you tend to cost more in the hospital system, and overall costs are close to $4,000 more. So that's very interesting data that we need to do a bit more work on, but is very telling as well. So it comes to, you know, the kind of the last part I want to get to is, you know, how do we measure outcomes for people with aphasia? How do we do this better? And, you know, what we know is that many of these domains, like the EQ5D, like the modified Rankin, do not specifically collect any information about whether or not someone can communicate, yet we all need to communicate every day in our daily lives. So that is an issue. When people, there was a group, a consortium that got together, the International Consortium for Health Outcome Measurement, looked at what mattered most to survivors of stroke, and then that got mapped against the EQ5D. You can see here that there are some important aspects of care, like fatigue, like the ability to feed oneself, like the ability to communicate, that are missing. And so this international consortium have provided additional measures that they recommend we should collect. So last year with, over the last 2 years with Darshana, who's a postdoctoral PhD early career researcher working with me, we undertook to add these extra questions to the usual follow-up survey of OSCAR. So we included these extra things that were missing. Now, what we found for people reporting communication problems, so this is interesting because if you think about what I said earlier that 44% had either dysphagia or aphasia, what's been self-reported back from these 234 people that responded, 70 of these people had problems with their ability to communicate. So that's about 30%. So that's kind of getting closer to that 23% that just claimed to have aphasia in the work by de Kock. Now, one of these people needed feeding with a tube. 46 reported some level of fatigue, and 3 reported severe fatigue. 11 reported poor cognitive or thinking skills, and 21 reported poor social activities and participation. So again, if we don't account for these types of conditions in our cohorts, we might be missing really important factors or subgroups that we should be doing more for, including follow-up. Of the people that also communicated problems, had communication problems, when we looked at other aspects of the EQ5D domains, you can see here that the greatest issue for them in this sample was usual activities, problems with mobility, pain or discomfort, as well as with personal care. So that aligns nicely with that other data that I showed you. But what was most concerning for me is that 86% of these people, these 70 people that reported that they had communication problems, were either moderately anxious or depressed, or self-reporting being extremely anxious or depressed. Now, are these people becoming invisible and we're not seeing them, and we don't even know how to find them because we don't know that communication problems could be a major driver behind all of this? So what are the future directions for OSCA? Well, we want to trial other options for responding to follow-up surveys, such as using SMS, and that might be a way in which another form of communication or strategy for getting more people to respond. I think we do need to look at particular subgroups of patients, and we need to consider mechanisms for how OSCA can feedback information as part of providing better value-based care in the health system, and continue to explore data linkage options so that we can minimise responder burden, but also the data collection burden for hospital clinicians that collect the data, or those out in the community that are doing work in stroke, as well as the extra ICHOM measures being more routinely added into our surveys. So this is the sort of way we're going. But with the CRE in aphasia, what we have done is we've got a collaborative program for data enrichment, and we're really trying to tackle now what should be the minimum data or the processes of care for measuring on people with aphasia. So this is a piece of work that's been done with David Copeland, Erin Gadecki, Monique Kilkenny, Sarah Wallace, with support from Emily Brogan and a new PhD student, Katie Chad. So you'll hear more about that through the CRE over time. And what we really want to end up with is a systematic and standardised monitoring process for care and outcomes. So that can be used to improve services and address unmet needs for people with aphasia. And so how this will be done is that it's not an easy process to determine. You know, you can collect 1,000 things and we'll all have our own view on what's important to collect. So we need to go through this process of taking everything that's relevant, breaking that down into things that are considered most important to collect on everyone all of the time, because that's what a minimum data set in a registry needs to do, and then working through a process of pilot testing those variables, assessing their reliability and validity in the field, and then working through a program where they could be incorporated as part of, you know, the Australian Stroke Clinical Registry, or a national program of auditing, and then matching up the outcomes so that we can inform policy and practice. And if, for those of you who are interested in the work that's being done on better measurement of outcomes for people with aphasia, some of the current initiatives that are being driven by Sarah Wallace includes the Roma Core Outcome Set project, and there's an NHMRC funded project called Meaningful Evaluation of Aphasia Services, including patient-reported outcome measures. There's the MamaQ project. So please reach out to Sarah if you want more information on that. So in summary, the Australian Stroke Clinical Registry and the Australian Stroke Data Tool provide essential infrastructure for reliably monitoring stroke care. We now have the ability and know we can readily link and merge data across the whole patient journey for stroke. We acknowledge there are some gaps for capturing people with aphasia, but we can capture some of this indirectly through the ICD-10 codes, but that has some limitations, and we can think about through the work of the CRE what we might need to do to capture better data routinely through these administrative data sets. And through our active collaborations, we will have that ability to more reliably monitor care and outcomes for people with aphasia and stroke, and use the data to implement service improvements, because just having data for data's sake is not really useful at all. So I think I just want to, the main take-home message, I guess, is, it's nice to have lots of things, but we've got to be efficient and we've got to pick the best, and that's what a minimum data set is all about. Picking the most relevant and important things that will have an association with outcome, will be modifiable, will pick up variation in practice, but if we do something about it, will add to better outcomes for people. I just want to acknowledge Jisip Kim, who did that analysis for me on the aphasia data using the Stroke 123 data set, Darshana for her work on the ICHOM information, Erin and Sarah for providing some information about our collaborative work. And importantly, the team at Oscar Office, Sibylla Breen is the National Coordinator, and we also have, ways in which you can follow us as well on social media and get more involved in our program. And we are looking for an allied health representative on our Quality Improvement Committee, so that EOR is out at the moment. So thank you. I hope I haven't taken up more time than I should have, but I hope you found that all interesting.
Oh, thank you, Dominique. That was just fabulous. Such a huge achievement, and so fantastic to see the progress that Oscar has made over the last 10 years. Thank you for that very clear and comprehensive presentation. If you're happy, we've got a bit of time for questions that have come through, which we'll share that screen now. So we've got some questions and comments, which is really lovely. Kira's just popped up there, really interesting points about what we are actually measuring and capturing on outcome measures. Do you think that...
Caroline, do you want me to stop sharing my screen? Or?
I think Callie's managed that.
Okay.
Yeah, so the questions are showing on the screen now. Thank you. Kira asked, do you think that there would ever be capacity to adapt the MRS to capture how communication contributes to disability, or is it too established?
I think it's too established. I think you need to make sure that we have another way of capturing that along, like the ICHOM set. I think we need to push more for something like ICHOM to be used more routinely, because the ICHOM outcome set actually includes, you can use the MRS with it, but it has those extra questions. So I think as researchers or academics or clinicians working in this space, don't just settle for the MRS or the EQ5D. Take the ICHOM set and capture the whole lot, and then you can compare your work to other work. You can include the fact that someone has a communication problem in your analysis as a factor, because I think those are key things that we can't adjust for if we don't even know that someone's got that problem. You know their age, you know their gender, but what if most of it's driven by the fact that they're not able to communicate, and that's driving a lot of the depression and anxiety or poor quality of life?
Yeah, thank you. A comment from Miranda: communication is essential for usual activities and often missed as an ADL. Marcella said, great to see follow-up questions revised to include communication outcomes Is the method of follow-up sensitive to the communication needs of this cohort? For example, specifically designed to provide communication supports?
So that is a good question, and I think that's where we have to do the work to make sure that we have a version of the questionnaire that is able to be completed more easily for people that have communication problems.
Yeah.
If that's what you're asking. So that's where I think the CRE needs to hit its stride and really provide the tools and support to people, you know, and the registry in working through some of these solutions and having those options available.
Yeah, that's right. Miranda says, wonder how thrombolysis and clot retrieval impacted the European incidence compared to OSCAR data. For example, year collected. Is that a...
I'm having trouble understanding that question. Was it meant to be European incidence?
Maybe a comparison.
Thrombolysis and clot retrieval is a treatment. It doesn't really influence incidence as such. It's not they're not prevention, they're treatments. So maybe Miranda can talk to me about that offline if we've got cross wires on that.
Yeah. Okay. John asked, critical care costs were the one thing that were noticeably higher in those without aphasia. Any hypothesis about why?
It could be that they're different types of stroke. Maybe it's more of the hemorrhages and things are going into ICU, but we will have to look at that in more detail. But that's a good point. Thanks for raising that, John.
Yeah. And Miranda's comment, so fantastic to have these additional communication measures added to the fabulous data already collected. Yeah, so that's great. Are you able to update us any more around the work, the collaboration between OSCAR and the aphasia research team?
So, look, we're at the point where we're having regular meetings, but we're really in that first phase. Like, we're not ready to do the uplift into the registry yet. And, you know, we are actively needing to seek research funds. So we're doing the preliminary work as a group. We're working out what will be part of that minimum data set. You know, there's a protocol that's been written, and that first phase work still needs to happen and has started. I know Erin Gadecki's had to leave, but I don't know if Sarah wants to make a comment. But, you know, we're progressing that part, and then that will integrate into that next stage, which was that nice funnel plot like kind of diagram.
Yeah, great. That's excellent. Well, that looks as though we've come to the end of questions, Dominique. Thank you so much for your time today and this excellent presentation. We really appreciate it. I'll just
That's okay, and I'd be really keen to know what people think of the ICD-10 code issue, and whether anyone that's working in hospitals has ever spoken to the clinical coders and worked out how they're doing that, because I would love to know.
Okay. We'll get back to you.
That's my challenge I'm putting back to the group.
Okay. Just to let everyone know that we have another great seminar lined up for next month by Professor Julie Bernhardt from the Florey Institute of Neuroscience and Mental Health, and she'll be talking to us about stroke rehabilitation trials and a multidisciplinary approach. So thank you all for joining us, and we look forward to seeing you then. And thanks again, Dominique. See you.